Well, thank you for tuning into this specially specific recorded session that we hope will support your preparation for ARCPs, and that's both for trainees and trainers. And so I'm delighted in this cardiothoracic session to be joined by Professor Jahangiri, who is the chair of the Cardiothoracic SAC. Professor, I wonder if I could ask briefly for you to describe your thoughts on the new curriculum and how they work into orders to the ARCP for your trainees this summer.
Hello, Mr. Jones. Thank you very much for this opportunity. Ladies and gentlemen, our trainees and our trainers, I would like to take this opportunity to tell you about the new curriculum in cardiothoracic surgery, which was published in August 2021. This is now 7 years since the last curriculum. The purpose of the curriculum is to produce at certification competent doctors who can deliver excellent outcomes for our patients as consultant surgeons. The majority of the cardiothoracic service needs is either cardiac or thoracic. However, you will qualify as cardiothoracic surgeons having been trained in the specialty of cardiothoracic surgery as registrars. And you can apply for posts in cardiothoracic surgery, but I would say 95% of the consultant jobs now in the UK and Republic of Ireland are either cardiac or thoracic. I'd like to tell you a little bit about the training pathway. Trainees can enter this training program via a national selection under two pathways. One is following foundation training for run-through doctors, or following core surgical training for uncoupled programs. It is outcome-based and not time-based. However, it has an indicative number of years. So for the run-through trainees, that is the non-core trainees, it is 7 years. Previously was 8 years. The 7 years has 3 phases. Phase 1, 3 years, phase 2, 2 years, and phase 3, 2 years. So 3 plus 2 plus 2. For our core surgical trainings who won't enter the specialty, this is 6 years. And the difference is that the phase 1 is 1 year shorter. So 2 plus 2 plus 2. There are some critical progression points from these phases. As you heard Mr. Jones discuss preparation for ARCP. I will explain to you exactly what you need to prepare at each stage, but it's not quite prescriptive. There are some critical progression points. In your phase 1, you will be assessed by your educational supervisors and the training program director. It's an annual assessment. However, you will be assessed 6 monthly and at the time your entry at the beginning of each year with an educational contract. This is the phase 1. At the end of the phase 1, you'll have your major ARCP to go into phase 2. At that point, the trainee decides whether they want to do cardiac or thoracic. That is a critical progression point from determining what is going to be your main subspecialty. Phase 2 has an indicative time of 2 years, but it's very important that when you're on call, you'll do both cardiac and thoracic. So you're on call for cardiothoracic surgery. This will give you the opportunity to obtain the necessary skills. At the end of phase 2, you can take your first exam, Intercollegiate Specialty Board exam, where you demonstrate various areas of knowledge and your professional skills. I'm not going to go into the details of the exam with you. Then phase 3, which is your last phase, is another 2 years. You'll be operating more or less in the same capacity. Again, whilst you do on call, you're on call for both cardiac and thoracic surgery. In your very last year, we aimed at working with your training centers that you do less on-call as, if you like, the senior registrar. However, it's 2 years and on-call requirements are more or less the same. The difference between phase 2 and phase 3 is that there's a gradual reduction in the level of supervision, and it's increase in the complexity of the cases managed by our trainees. There is capabilities in practice term, and in cardiothoracic surgery, these are 7. I was discussing with my colleague, Mr. Keith Jones, as what is these index procedures or critical conditions that is discussed in cardiothoracic surgery. Index procedures, essentially, they're common operation, but very important for you to achieve excellence in them because it provides you with the 50% of your practice and it equips you with dealing with everything else. So it's essentially the very basics of your specialty. In cardiac surgery, it's isolated first-time coronary artery bypass graft surgery, isolated first-time aortic valve replacement, and combined aortic valve replacement and coronary artery bypass graft surgery. You may think that I'm giving you a lot of information. Please look at even print out a copy of the new curriculum and look at it. It gives you a good guidance as where you need to be. For thoracic surgery, it's anatomical lung resection, either open or video assisted, decortication of empyema, and management of pneumothorax. Again, please have a look at them. There is another term when it comes to discussing the conditions and operations you need to do. These are called critical conditions. Critical conditions refer to conditions that, if they're missed, they have significant implications for the patients and consequences for life. We can go through the details of these conditions later. However, they range from aortic dissection to myocardial ischemia and infarction and acute hemothorax and cardiac tamponade. So it's very important that we equip you with knowledge and management of patients with critical conditions. So by certification, you should have documented evidence of all these conditions. Now, many of you ask me, well, how many cases do we have to do before qualification? The number is 250. However, please note that this is not a strict number. Some of you may have obtained equivalent experience in other specialties. Maybe you've chosen to go to a subspecialty like pediatric cardiac surgery or transplantation or more intensive care. But there is an indicative number of 250. Now, as you heard, Mr. Jones set out at the beginning that we want to help you to prepare for your ARCP. Please don't do it the night before. You need to have very good documentation for your portfolio. Work-based assessments, multi-source feedback. Just look at the assessment with your clinical supervisors and your program directors about your CiPs, evidence of examination, evidence of courses you have attended, and multiple consultant reporting. Have all of these in your portfolio. Please don't compile them and do them right at the end. Please do them as you go along. In essence, if it is not documented, it hasn't happened. You may have done 500 cases and you're an excellent and a very able doctor and a very able technical surgeon. If you haven't documented it, it hasn't happened and it will cause problems for you at your ARCP. So please, may I urge you to document these properly. And then, of course, you have your supervisor's report. Then my penultimate point is, some of you ask me again, what are the requirements for certification? There are several requirements, and I'll outline them for you, and they are in your curriculum, which you will be downloading and reading, please. You need to have full registration with the General Medical Council. or registered with the Council in Ireland, Republic of Ireland. You should have successfully passed the Integrated Specialty Board examination, which has 2 parts. You should have achieved level 4 or level 5 in all your CiPs. There's 7 CiPs in cardiothoracic surgery. Please read them. It's in the curriculum, and level 4 is essentially operating independently with no supervision, as if you're a first-year consultant cardiothoracic surgeon. You should have achieved your competencies described in the 9 domains of general practice capabilities. And you should have been awarded an outcome 6 at the final ARCP. I am sure you will all achieve this, and not just achieve this. This is the bare minimum I have outlined for you. You will do much better. I would like to end by saying all our trainees and your trainers, including myself, were highly privileged individuals to have obtained the trust of our patients to operate on their heart and in their lungs and conditions associated with them. So we have to do our very best to deliver the care. Thank you very much, Keith.
Thank you very much indeed, Professor Jahangiri. Thank you for highlighting in the separate parts the index procedures and then the critical conditions. The index procedures in each curriculum are available to be seen in Appendix 4, and so that's where I would recommend that the trainees and trainers look to find them. Can I just ask, in relation to the index procedures, is there a number of PBAs that are required by the trainee? Is that different in relation to phase 2 and phase 3?
No, we don't have a required number for PBAs or WBAs. However, we do have a requirement for the overall case numbers, but if you like, a general guide is about 40.
Okay, and clearly the expectation would be for the trainee to have acquired PBA to competencies of level 4 at the end of phase 3 or within phase 3. Within phase 2 and the developmental area, you would be expecting PBA presumably of some degree of supervision.
Absolutely. It's essentially, it's not black and white or so clear cut. So we have to imagine that there are 2 if you like, graphs that they would move in a cross section in opposite directions. One is the level of supervision, one is the level of independence, and they have to ultimately cross and go in opposite directions. So increasingly, your level of supervision should decrease, and your level of independence and doing more complex and managing more complex cases, and your independence should increase. So I would say that is your overall progression in particularly in the last 4 years in phases 2 and 3.
And at ARCP, the trainees would be needed to show that they are gaining the experience in those index procedures. Should they just be showing that through their logbook, or would trainees be reassured that it will be represented within their MCR and other education supervisor feedback?
Thank you. That's a really precise, excellent question. Logbook as well. Our trainees, we have just revised the logbook for cardiothoracic surgery. Please use it, because that gives you, if you like, a printout or a summary of your various cases or parts of cases, and is familiar to all your trainers. So please, you have to include your have your logbook, which is now part of the ISCP. It's just been revised.
Excellent. And is it fair to say that a trainee's logbook they will all vary. Trainees shouldn't be concerned that their logbook doesn't necessarily look like their immediate peers, because their route to competency may be on a different trajectory.
It may be, but at the same time, it shouldn't provide a complacency. It's a highly competitive area. All our trainees are highly intelligent individuals with excellent curriculum vitae and portfolios who've entered. I would find it difficult if they stop being competitive, and I hope they continue to be competitive and competitive for excellence. Good.
Of which excellence would be represented within the CiPs in the MCR level 5. Now, Professor, if I could ask about the critical conditions. Which you very kindly defined for cardiothoracics, and those are available as a list in Appendix 3 of the curriculum. There are 9. My assumption, all of the 9 obviously are vitally important as a skill and knowledge set. There would be important that the trainee had the clear, from a training post, that the trainee would have had the opportunity to be exposed to all of those during each phase of the curriculum, or are there some that would be exposed to at a later stage?
I think there are conditions which the trainee can be exposed and is exposed during the entire part of their training, but particularly in phases 2 and phases 3. I'd like to use this opportunity and tell our trainees and trainers who are in charge of the rotas and scheduling. A lot of these conditions, which are absolutely important and part of the curriculum, you come across them out of hours and on call. They don't happen at 2 in the afternoon. And at 2 in the afternoon, you're in the operating theatre anyway. So it's very important that you are around and you do your on-calls. Because there has been discussion, and I agree that there is a lot of, if you like, service provisions for our trainees and for any trainees in a hospital. However, it's very difficult to distinguish between the service and the training, and many of these conditions present themselves out of hours. I'll give you an example: cardiac tamponade. You finished operating at 5 o'clock, the person is going home, and the tamponade doesn't happen an hour later. The tamponade happens between 10 and midnight. And similarly, the admission of many conditions into the accident emergency departments.
That's very clear, because that covers my next question about opportunities of having gained the knowledge and skills required for those critical conditions. So thank you for highlighting the importance of the on-call aspect as well, to be seeing the patients when these critical conditions occur. And again, a question that I know the trainees will ask in relation to the ARCPs: is there a number of CBs or KEXs that are required to show this, or is it just important to have shown competence to CBD or KEX level 4 in each of the critical conditions?
I think the latter. There is no particular number, because let's say, for example, a cardiac surgeon and a median number of aortic dissections performed in the United Kingdom with aortic dissection is 3 per surgeon. So it cannot have a number. Similarly, let's say a number for tamponade, the post-operative bleeding or return to the operating theatre after cardiac surgery in the UK is somewhere between 3 and 4.5%. So the percentages are low. However, by being around, by engaging with your teams, you will learn the skills, and we will make sure that those have come across in your assessment.
Thank you. That's very clear. One of the new aspects of the curriculum is the MCR, and in my generic recorded session, I will have covered the aspects of the shared components of the MCR. Cardiothoracics has some very specific CiPs in addition, and I wonder if I could ask you about those. And how the trainees would be looking to gain and demonstrate the knowledge and skills within those, accepting that they're obviously part of the MCR, but what might a trainee be doing to ensure that their AES is aware of their skill set and that their supervisors feed that back? So for the CIP 6, the management of patients within the critical care area, what are the expectations?
Sure. And I fully understand why this is specific to cardiothoracic surgery. All patients in the United Kingdom who undergo cardiac surgery are admitted to an intensive care setting. If it is called sometimes high dependency, but there are settings which has a requirement of intensive care, i.e. ventilated beds. So if you're doing any cardiac surgery, our trainees will be exposed to the care of your patients on intensive care. Let me give you a practical scenario. So after surgery, you will accompany your patient with the anesthetic and intensive care teams to the actual intensive care area. You will do a handover. The trainee would do a handover. And after that, we'll get involved in the hemodynamic management of the patients. Less respiratory, hemodynamic, and if you like, renal management. The following day, the doctor has to go and see the patient on intensive care. So looking after patients in critical care is very much part of the daily life. And you will work, our trainees work with our intensive care colleagues and their own surgical teams when they go around and they learn. And they have to learn when the patient is stepping down from such an intensive environment. Similarly, for thoracic surgery, many patients are admitted to, if you like, higher monitoring settings. So, and we will supervise you, we will supervise our trainees, and we will make sure that in their case-based managements and other formats, they have said how they've looked after patients. They describe, for instance, if they've had a very sick patient, how they've spent, I don't know, 1 or 2 days with them to get them off their hemodynamic support and their ventilatory support.
Excellent. That's very clear. And it sounds to me that there's a large amount of collaboration involved in there. So with the CIP6, is there some degree of overlap into the multidisciplinary working aspects of CIP5 as well?
Completely. In that way, is I would say cardiothoracic surgery, particularly cardiac surgery, is the least independent surgical specialty. If you look at the team who go into an operating theatre, there are 15 of them and 15 come out. One is very dependent on the skills, knowledge of the intensive care colleagues and anesthesia. There's a very close working relationship with them, and everybody really cares for those patients, and there's a lot to learn. Especially now that the mortality in cardiac surgery has decreased significantly in the last 20 years. Our attention is turning into morbidity, reduced complications, and quality of life. Therefore, very important to work with those colleagues and learn from them and contribute to the care.
That's fantastic. Thank you. And that nicely segues us into talking about CIP7, which is the assessment of surgical outcomes, both at personal and unit level. What sort of activity or knowledge set would the trainee needing to be, or do trainees need to be looking at in order to assess this CIP component within the MCR?
Sure. First of all, it's very important in your educational contract, and when our trainees set out what they need to achieve with their trainers every year, that they record every complication that they have, any mortality, not necessarily any of these complications or mortalities that they have been involved with. Is highly important. It's also part of the logbook. This is very much the ethos and the day-to-day living of a cardiothoracic surgeon, but more so with cardiac surgery. It is a highly scrutinized specialty, both, as you have asked me, at a personal, i.e. surgeon-specific level and unit level, which we refer to as unit-specific. So please be prepared to have a very detailed logbook of your activities and of your complications and discuss them. All units have very detailed audit mechanisms and meetings that we encourage all our trainees to attend, and that should be part of your ARCP. Similarly, if there have been, if you like, incidences or serious incidents or adverse incident, whatever is your class measuring it, it has to be, you have to use that as a learning opportunity. So your trainers would really involve you with all that care.
That's fantastic. Thanks, very clear. And so there is a degree of responsibility, it seems, for the trainee to be aware of their own personal outcomes in relation to development, and an expectation that they would be able to discuss that and reflect upon it at their ARCP?
Completely, Mr. Jones. I think that's really important. And our trainees, I would really urge them to recognize you can't suddenly obtain responsibility at the end of year 7 when you've obtained your CCT. None of you think like that. I can see many of you take responsibility towards your patients, all of you, and the more you do, the more responsible you feel. And it's very much the feeling of ownership of the patient, that you are responsible for that patient. If the patient goes back for bleeding, if the patient has developed a pneumothorax following removal of the drain, and so on.
That's really helpful, and so I think we provided a clear guide for your trainees now of how they're going to be looking to prepare, what the important aspects are preparing for their ARCPs, and how to represent the new aspects of the curriculum. See the ARCPs this summer being a new experience. So Professor Jahangiri, thank you very much indeed. That's been really helpful. And again, thank you for your time.
Not at all. Thank you. And I thank the college for this opportunity.